Hello, and welcome to CalHIPSO's monthly webinar series. All attendees are currently muted. However, we hope to open the platform for discussion during the presentation. In the meanwhile, should you have any questions, please enter them in either the Q&A or the chat box at any time. Today's webinar is being recorded. The slide deck and recording will be available on our website, calhipso.org, within a few days of this presentation. We will share a link to our website via email when the recording and slide deck are available. And now, a short intro by CalHIPSO's Interim Executive Director, Deanne McCallan.
Hi everyone, this is Deanne. Thanks for joining us today. I know there's a lot of folks on this call who are in the Central Valley that are kind of still socked in with smoke. Paul, our presenter, is up in Oregon and pretty near the wildfires, as many of us are. So I hope during these COVID and wildfire days, everybody is faring as best they can. We are continuing to bring you presenters from our sponsors of the CalHIPSO conference that was, of course, canceled back in May. That was covering, essentially trying to cover all things interoperability. And we're going to be continuing in that light with a webinar next late in October. And hopefully we'll be hearing from some of, and Lauren, there's some background noise, thanks. So hopefully we'll be able to hear from some folks from the ONC on the interoperability rules as some of the deadlines to be compliant start to hit upon in November. But back to today's webinar, we're joined with by OCHIN's Paul Matthews, Chief Technology Officer. Paul is also OCHIN's Chief Information Security Officer, so really well-rounded on talking about the topics. Over the years, he's focused on health information technology and secure information exchange and has served on a number of boards and committees such as the Sequoia Project, eHealth Exchange, and Epic Care's Care Everywhere Council. Today, Paul will be discussing electronic case reporting. And with no further ado, thanks for joining us today, and I'll pass the controls over to Paul.
All right, well, good morning, everybody. Here is my pretty face. We'll move on immediately. We're going to cover a topic today, a brief introduction to OCHIN, just so everybody's aligned on who we are and why we're involved in electronic case reporting so heavily. Second one is a brief introduction to what case reporting is and how that aligns with electronic laboratory reporting. We'll then get into what the electronic case reporting program is through the AIMS platform and leave time open for a lot of questions. Because I want to make this an interactive session as much as possible. So OCHIN is an organization that's been around for about 20 years, predominantly focused on serving organizations in the safety net realm. So a lot of public health organizations, safety net clinics in the ambulatory environment. We host a number of EMR products. The one that predominantly I'm focused on at this moment is on our Epic hosting side. But we've also done integrations and hosting with NextGen, eClinicalWorks, and support of other EHR products around the country. To sort of give you a scale of OCHIN, we're about serving about 20,000 providers across 47 states, see about 170 million record exchanges per year coming across us. It's actually higher than the 151 shown on the slide deck, and cover a number of organizations, school health centers, corrections facilities, behavioral health facilities, and a lot going on around the COVID work today. From a population level, a very diverse population, as you would expect in a federally qualified health center environment. From a diversity, these slides will be available, and we'll let you go through the detail in these slides in great detail. From California perspective, we have a lot of services that we provide in California, including the 33 organizations that are using today our Epic environment, including 25 federally qualified health centers up and down the entire length of California, from San Diego up through Humboldt County. And these are the organizations that are delivering services on the front line, as many of you are in this COVID crisis. Again, it's actually 33 members, not 29. I apologize, one slide is slightly out of whack here. But that's about 1.3 million covered lives, so unique patients that we're seeing through the EHR platform that we're hosting and delivering case reporting from. So then we'll get into the actual meat of the topic. The main meat of this topic is around case reporting and what is it. So as many of you are aware, there is a requirement for case reporting to be delivered from providers to public health authorities in your local jurisdictions. And those reporting mechanisms take one of two paths today. They're reported either through the EDI platform, or they're reported through directly to your public health authority through manual, either faxing or manual delivery via phone. In those instances where reports are being delivered today, they are suffering from a lack of quality of information in many cases when the report arrives at public health. This causes a delay in the ability for public health organizations to do outreach and contact tracing work because they're not receiving necessarily good contact information for the patient or low quality contact information for the patient. And I'll give you a couple of examples. The delivery of a patient address may not be included in the reported information that's coming from a laboratory system. The information being shared about an email address or phone number often is not the phone number of the patient. It's often the phone number of the clinician provided the services or the organization that provided the service, which means public health authorities are having to reach back out to the clinician to get the information on the patient to start contact tracing and outreach requirements. This is delaying care for our patients, and this is actually causing an increase in the manual workload and the resource strain placed on both public health and on the clinics themselves. The other place where data is delivered in case reporting is through electronic laboratory reporting. Most of the time, this is dealt with by the labs themselves or by the hospital systems, but a number of clinical organizations are now providing point of care testing for COVID-19. And when they provide that testing today, what's occurring is they're now starting to get requests to deliver laboratory reporting data to public health as well. This is unusual for most primary care providers that are not normally requesting being sent laboratory test results directly, when it's normally sent out to a reference lab to do those types of work. The ELR data itself is often sent through HL7 interfaces, and those HL7 interfaces is not something many EHR implementations in ambulatory practices have ever implemented. So they're normally resulting in manual reporting again, or in creation of flat file reports that need to be delivered. So what does electronic case reporting do? So electronic case reporting will allow the electronic transmission of these reportable conditions to meet the provider's requirement, mandated requirement to report. And these were baked into meaningful use stage 3 requirements. And in California, there has been a setup called the CalReady platform that we'll cover in a second that is there to receive these, and as it has in many other states. But we've bumped into issues around capacity in every state. So this is not a California specific issue. Every state is dealing with capacity problems and performance issues with the receipt of the quantity of data around case reporting. When we look at case reporting itself, electronic case reporting, the California Reportable Disease Information Exchange, CalReady, was developed and has the ability to receive all of your data electronically under the meaningful use criteria requirement. However, the volume of data and the increase in the number of organizations sending reporting means that data is not being ingested or is currently not capable of being ingested at this time. And the organization is moving quickly to actually implement changes to actually be able to ingest this data. And so while we're delivering case reporting to CalReady today from many organizations that I'll cover in a minute, that data is currently not being ingested and is being worked on to make that the computerized information available. We will cover, however, that the information is being sent in a manual human readable format, and we'll actually show you what that looks like when it arrives at the public health agencies. So to cover the history of this, back in 2012, there was a goal to modernize healthcare across public health. And in that program, an implementation of what's called the Association of Public Health Laboratories Informatics Messaging Service, AIMS, was created. This is a centrally hosted, cloud-based in Amazon Web Services solution as a gateway where healthcare provider organizations can submit a document to this central gateway where it will be reviewed and forwarded to the appropriate public health agency. They were in implementation of this in pilot up as far as February of this year. And when COVID hit, we moved rapidly to look at how could this move away from a pilot and move to deliver data for COVID-19 to assist in this emergency. And so when we look at the way the implementations of the electronic health system today, you need to think of these in terms of the last 6 months, where we actually went from a pilot testing in about 4 organizations across the country to implementing hundreds of organizations across the country and delivering millions of case reports through a centralized platform to public health. And I will actually show you a much more clear picture of this later in the slide deck. Now, what's important to understand when delivering data through this solution, through this AIMS platform, is there's a legal requirement that needs to be put into place. So providers meet the delivering data under the public health carve-out under HIPAA. And so you are able to deliver what's called the minimum necessary data elements through to public health from your electronic health record in an electronic format. And the design for this meets all of those criteria to meet that public health carve-out requirement. It is delivering remotely a copy of a CDA document, so the normal exchange documents that you would see between yourselves and other HIEs or other providers, but it has a specific carve-out of elements that reduce it down to meet the minimum necessary to deliver to public health. And I'll actually bring up a copy of what it looks like for you right after this deck is complete. To legally send the information, there needs to be, through the AIMS platform, there has to be a contractual obligation met. That contractual obligation is met in one of 3 ways. The first mechanism is to establish a BAA agreement, either by being a member of the eHealth Exchange through the DIRSA, which is the Data Use and Reciprocal Support Agreement, the framework that allows you to connect up to the eHealth Exchange or the eHealth Exchange Hub. The second is through being a member of Care Quality or through your vendor having signed on to the Care Quality Connection terms. So if you are a member of either of those 2 contract options, you've met all of the legal criteria and have a BAA in place with AIMS to deliver data to public health. The last option is to enter into an APHL participation agreement that is a standardized document nationally that can be signed between your organization and APHL to establish the business associates agreement. It's a standardized agreement and there is no option to modify that agreement because it has to stand across the entire country. And so those are the 3 options from a legal standpoint that offer you options to join into this program. Then there's a question of transport. How do you deliver to public health and what options are available? So 2 options for delivery are available today. The first is through direct secure messaging. This would be through your health information service provider. So a lot of organizations will use organizations like No2, maybe your local HIE is providing those direct secure messaging services, or SureScripts in a lot of cases. And the other option is to send it through the eHealth Exchange Hub as a push. This is a brand new solution that went live late last month. We helped develop the solution with eHealth Exchange, with Epic, and with APHL. And this allows for organizations connected to the eHealth Exchange to also send their data through a push in that mechanism. So how does this flow and how does this work? Today, inside the electronic mechanism, we would build out in the EHR, or excuse me, a little smoky. We would build out in the EHR trigger values that detect when a COVID or other condition has been received. So this may be within the problem list, within the VISIC diagnosis, or within a laboratory result, both within a positive and negative result in those cases. If those triggers are matched, it will then trigger the creation of a reportable message. So it'll actually create the CDA document that needs to be transported to the AIMS platform. Through that mechanism, it will choose to either go through your direct secure messaging or be delivered through the eHealth Exchange hub, and then reach the AIMS gateway. On reaching the AIMS gateway, it actually will then be worked on by a rules engine, the RCKMS rules engine. And this is a rules engine that is updated and modified by your local jurisdictions. So the jurisdiction will go in to this platform, edit the rules for COVID, which will evaluate, is it a reportable condition? And if so, what the next action to occur is. The other thing that the RCKMS engine does is it looks at all rules from all jurisdictions and determines if the place of service for that patient is, say, in California, that it applies the California rule set, and then will forward those messages on reportable conditions to the local jurisdictions in California. And it will also evaluate the patient's place of residence to determine if the place of residence of the patient is in California or is in another state. If it is in another state, it is often required that reporting conditions be sent to the home residence jurisdiction of that patient, and it will forward on the same report to that local jurisdiction in the place of residence of that patient. This is often an area that is missed by provider organizations when reporting today, and results, if for instance, in some cases, I've heard in Lyme disease, where 1 in 10 reportable cases are actually reported to public health. And so the goal here is to make it very easy for the provider to deliver the information from their EHR, fully automated, to the AIMS platform, have the rules engine be applied that have been edited and updated by the local jurisdictions, and then have those rules determine where the report needs to go and the next step of that report. Once those reports have been evaluated and forwarded, an actual reportability response, a kind of receipt, is sent back to the EHR platform, and that reportability response will contain information on which jurisdictions receive the information and additional information for the provider to be filed back into the chart. Predominantly, that data today is really an acknowledgement or an audit level requirement that goes back into the patient's chart so that you can show a patient that information was delivered and show that you've actually delivered on your case report to public health. At a high level, when we look at it today in electronic case reporting, a patient may receive a diagnosis as a reportable condition. The healthcare provider is going to enter the information into the EHR. The data will automatically trigger a case report with all of the underlying information, which I'll cover in a second, and deliver that information to public health. That information will be received at the state level in most cases, and the state will then forward that down to the local jurisdictions. In the case of CalReady, it would reside at the CalReady facility, be ingested into the CalReady platform and delivered down to the local jurisdictions. In California and in a couple of other states, some local jurisdictions have requested that the information be delivered directly to them, LA County being one of those. And so in those cases, a direct connection is being established between the AIMS platform and LA County. And so the information is flowing directly to LA County for those case reports being delivered. To sort of show the scale of growth that has occurred since April. With 4 organizations live in April, we now have 4,900 facilities across the country delivering data. These are the roof locations of every clinical location that is participating in case reporting electronically today through AIMS, and does not mean that this is a list of every interface that is being created. For instance, OCHIN accounts for 800 locations across the country, and those 800 locations come through one interface through our Epic implementation and are delivered to AIMS from our facilities in Portland. To sort of show you a scale of that operation, The graph at the bottom is showing the numbers of case reports delivered through the OCHIN platform from its member clinics across the country that have been delivered since April 17th when we went live. So we've delivered 171,000 electronic case reports to local jurisdictions through this program. Some states are no longer requiring manual reporting. So for instance, there in Oregon, the case reports make it to the jurisdiction. The jurisdiction incorporates those into its current public health system called Orpheus. And then the public health jurisdictions at the local county levels are able to see all the information in the Orpheus platform. So there's no longer a need then for manual reporting. And to give you an example of what that looks like, one hospital in Florida that received the go-ahead to stop manual reporting when doing electronic case reporting is saving upwards of 800 to 1,200 hours per week, depending on the numbers of visits occurring and the numbers of cases that trigger events, but are saving that on a regular weekly basis for resourcing within staff. They've then been able to concentrate those staff on other efforts serving the public. The big one for us is to look at is, can we move the public health side of the house when receiving this data to no longer receive a manual report? And can they receive the data electronically and then help in the public health crisis to actually help outreach staff then do a better job of outreaching to patients, not reliant on manual re-entry of the data they're receiving either via fax or via phone call. And so this is the main purpose of electronic case reporting: more accurate information, more timely information at a higher level of quality that is immediately actionable. And this may help all of our public health agencies perform their duties during the crisis. One of the other areas that might be interesting on this slide is you may see in some cases very small dots. Here in northern Texas, we might have some cases in northern Montana, in areas in other parts of the country. And often when we see this, if I was to drill into my reporting platform and only show reports where services were performed in California, I would actually see delivery of reports in other states. Those are those patient level residence reporting criteria automatically taking place. So we're able to see a much higher level of reporting than we've ever been used to before. So today, all 50 states are receiving and are connected for electronic case reporting to the AIMS platform. There's also nine very large jurisdictions that are also connected, and one small jurisdiction that is also connected for delivery through the AIMS platform. Of all of those jurisdictions, we've got 1.8 million reportable COVID reports sent through that have been deduplicated and sent on to the public health jurisdictions themselves. And that's information as of this morning. I apologize, the slides I had sent over last night, Colleen, were as of a week ago. So what's the important information that's being added to this? So within the ECR, which complements the electronic lab reporting system, we include additional data: date of birth, sex, race, ethnicity, and social history, the address and telephone and email address, if appropriate, of the patient and not of the organization, although that information is also inside of this report. We include lab results, both positive and negative, to be sent to public health. The public health jurisdiction themselves need to create their rules and aims to receive negative results and not just positive results, and many of them have done that today. We also will include the existing problem lists on the patient, medications, immunization data, and additional information so that we can actually look at additional conditions that may exacerbate the patient's condition under COVID. It also incorporates the ability for point of care testing results. And so the ability to edit and enter results into the EHR for non-interface laboratory systems and non-interface testing devices. So today you may be used to public health receiving information from your reference labs like Quest and LabCorp and other reference labs, or maybe your hospital system. But as you're taking place in point of care testing, you're also then entering that information in, and that same data can be delivered to the jurisdiction through ECR. Once ECR arrives at the public health agency, they receive it in two ways. They receive a human readable format and a machine readable format. The human readable format, which I'll demonstrate in a second, is a rendered HTML file that can actually be read and copied by an individual directly into the public health system, replacing the fax solution, which often loses fidelity of the document or may have limited information necessary to get the reporting done, but may not be accurate information or of the same quality that is available in the human readable delivered document. The machine readable format, it's an XML CDA document, can be ingested through and into the public health system and then dispersed for use by public health. Now, ECR is also designed to expand beyond COVID reporting. So in many cases across the country, there's about 10 organizations today that are delivering upwards of 10 reportable conditions to public health in different jurisdictions. These may include STIs, tuberculosis, other reportable conditions they considered very important early on in the testing. At OCHIN, we have just kicked off our project. Our goal is to build out all 89 reportable conditions that may have changed in the last few weeks, but there's currently, we know of 89 reportable conditions that we will be building out that will then trigger and deliver reports to the jurisdiction. Now, it's important to understand that in our case, we deliver to 19 states immediately upon those triggers, and we will be building out on a state-by-state basis the deliverable of those additional reportable conditions so as not to overwhelm those states that do not wish to receive electronic case reports for non-COVID conditions today. Our hope is that all states will allow us to deliver all conditions reportable and remove the need over time for reporting of any condition manually to free up those capabilities to the provider. To sort of show the breadth of the organizations that have currently implemented, and then we'll talk a little bit about how this is different between, say, large hospital systems and the provider community and in the ambulatory space. So as we see in here, numerous organizations across the state. UC Davis, who was one of the pilot organizations prior to April, Sutter Health, ourselves, Contra Costa, Memorial Care, UCLA, UC Health in California, along with Eisenhower, John Muir, and others. These slides will be available, and you can certainly look at these to your heart's content. Are all live and all actively sending ECR data today. There's also an additional list of organizations that are in implementation as of today, and those include in California Community Medical Center, Washington Hospital, and others that space. Valley Medical and Kaiser are also delivering data today. And so this is information that is being pushed out. We have a number of cohorts. Myself and Stephen Lane at Sutter Health have been partnering up with the CDC and with the AIMS APHL organization to make certain that this is getting out in front of provider organizations so they know how to implement and who to call if they're interested in implementing ECR within their organization. Just to sort of show what it looks like on the ground, every single jurisdiction, every state has currently received, except one, an ECR report. That state is connected to the AIMS platform, but they are still in implementation in that state, and no patient from that jurisdiction has currently been seen in another jurisdiction that is connected and working. And so they've not received currently a report in one state. Actually, in one county of one state, I should say. So with that, I'm going to switch over from the presentation very briefly and demonstrate the actual ECR record itself. And this may be very helpful for those that are sort of more graphically inclined. So on the screen, you will see the human readable version of the ECR report that is delivered to public health through this AIMS platform. We can see the patient information themselves, the demographic data on the patient, the race and ethnicity data, the contact information for the patient if it's available in the EHR platform, the author, organization, the contact information for the authoring organization, this being the provider organization, the encounter data, including the COVID information or any other condition, any other history for that patient, including travel information, any medications administered to the patient, the problem list, the reasons for visit and the results, both positive and negative, any plan of treatment, social history, immunization data, and the contact information for the hospital itself where the main document is being maintained. And so with that, we've reached the end of the presentation, and I wanted to be able to open up to questions from the floor.
Thank you so much, Paul. So yes, I'd like to remind everyone that we do have a Q&A box and a chat box in which you can submit any questions that you have about today's presentation. We don't have any right now, so while people are maybe throwing their questions in there, I will remind everyone that this presentation has been recorded and we will be providing that recording after today via email to you, as well as the slide deck from today's presentation.
Lauren, this is Deanne. I'm curious if folks do have a question, if we're able to unmute them to have them verbal, wondering about that. And yes. I guess I have a question for Paul to potentially start some dialogue. What I wonder about is duplication of recordings. So, you know, it seems that this was a lot of focus seemed to be patient level EHR provider, like provider patient EHR.
Yes.
But what about that they weren't doing the point of care report, or they were, and it's going through the ELR and not the ECR versus all of that. So a little bit about how the systems are avoiding duplicity.
Yeah, so public health has been receiving duplicate data for quite a while and is very familiar with the deduplication process. They've seen this as well with immunization platforms and other platforms. If we look at how data is reported today, say in an organization that is connected through in a state that doesn't stop the requirement for manual reporting. So they would receive a patient's data via electronic laboratory reporting, either from the hospital platform or from the reference laboratory. They would receive the data in an electronic case report if you're connected up to the AIMS platform. They would receive the data via fax or manual entry mechanism through the normal reporting mechanism you're using today. And they would need to then incorporate and deduplicate that information in their case reporting tool. And so they're tracking in their public health system, they would be tracking and deduplicating at that level. And that's occurring today. The issue in the way it occurs today is, as we know, if somebody is doing manual reporting or is calling it in, we may end up with letters being rearranged in names. We may be reporting on a slightly different name. We might be calling it Bob Smith as opposed to Robert Smith. We may be transposing dates of birth. We may not be including enough information to really narrow it down to the individual patient, which then requires public health to call back to the clinic and actually ask additional questions on that patient to determine if it is a duplicate. And so making this more electronic is actually a better path to go down. And even in electronic case reporting, you might receive multiple triggering events that create a trigger that delivers. Because the moment it's added to a case report, to the problem list, it will trigger a case report. The moment it's added to the encounter diagnosis, it will trigger. If you receive a laboratory result from your external reference lab, it will trigger that when you receive that result. If you do a manual entry from a point of care testing device test, and you enter that result into the EHR, it will trigger it then. So they're used to receiving multiple triggered events and actually deduplicating those. You're on mute, Deanne.
Thank you. Excellent. Paul has put his email in the chat box if any of you are looking to reach out and engage afterwards. Another question I had is, it seems a lot of high success and good operability with Epic. What about other EHRs?
Yeah, absolutely. So a lot of the major vendors are working on their implementations today. Cerner is close on completing their implementation for those on the Cerner platform. Additionally, Allscripts, eClinicalWorks, NextGen are all in development work to bring it up. For those that wish to implement it, or those running health information exchanges, an option exists to download and implement a product called ECR Now Fire. That is and I will make certain to distribute to you a link directly to that application. So for those that are technology based, there's a storage system called GitHub. You follow a link from the ECR website, you'll download the code, and you can create and implement a mechanism that will plug into any EHR via Fire. And so if you have an EHR that has enough of the Fire capability, the specification it needs to meet at a minimum is called DTSU2. That's the draft specification version 2. It was a very early spec of Fire. But this will give you the ability for this tool to reach into your EHR via Fire, look at its triggering events, understand which ones meet the criteria to create an ECR, create the ECR, package it, and deliver it through either your HISP or through the eHealth Exchange directly to AIMS in exactly the same path. And that's a standalone solution that you could put onto a little virtual machine and then run that tool yourself to do all of that work. And AIMS is, the APHL team is very happy to jump on with organizations interested in implementing the Fire Now application for that and help you with that implementation.
Great. And you actually touched on one of my follow-up questions was going to be a little bit about HIE. So you actually covered that proactively. We do have 2 questions in the question and answer box right now. I'm not sure, Paul, if you have access to it, but I can certainly read it to you.
I don't. So if you want to go ahead and read them to me, that'd be great.
And also, of course, for everybody else to hear. Does the ECR tell public health the kind of COVID testing platform used? There have been some concerns about reporting the results of COVID-19 antigen testing in hospitals or doctors' offices to public health.
I do not know the specific answer to that one. And I would hate to jump into it as a technologist, not knowing the provider side of the business. But I can certainly get an answer to that one and send that information over.
Okay, and Lauren, let's grab a copy of that to actually email it to Paul so that we have the exact words. And then another one is, what would you say to public health officials and the public who might have concerns about privacy with electronic reporting?
Great comment. So a lot of organizations will have concern that we're delivering their personal information to public health. This varies across constituencies. We experience it heavily in our communities of patients that we serve. This is a public health carve-out. This is no different delivering electronically than delivering manually to public health today. It will include some additional information that has not been reported today, but that still meets the criteria under the regulations, under state and under state law for delivery of that information. So we've looked at this. Numerous organizations, you've seen the listing, have looked at the criteria, and we've had very few people that have come back and asked questions around the limitations, or is there a need to put additional limitations on this reporting need. It does meet all legal criteria for delivery today.
Great. All right. So those are a couple of the questions. A few I thought of, a few others that I thought of I'm not going to ask because I feel like I'm too removed from the reality of the actual clinical workflow, but a lot of good stuff covered. And I think if nothing else, it probably, your presentation today has probably raised some questions on the how to and what they need to be doing. So folks should certainly reach out if that's where they are per Paul's presentation.
And I'm very happy to set up one-on-ones with organizations to delve into the details. If it's a group of provider organizations, either a controlled network, an IPA, that have questions, I'm very happy to jump on calls with them as well.
Great, thank you. We'll pause for a moment to see if any new questions come in, but if not, I'm sure everybody can use 15, 20 minutes extra back in their day, in this day and age, certainly. And don't forget, we are going to continue with interoperability and try to pull some of the different topics we've covered over the last couple months and this year's final rules that are coming down, with a lot of the compliance is due next July, because slight delays because of COVID, but there are some parts of it that take effect November of this year. And another thing I'll throw in here while I'm pausing, just to make sure there's no other questions, is meaningful use. So Paul touched on ECR is one of the 5 public health options that you can report yes to and become a stage 3 meaningful user. A lot of others are doing immunization registry. The CalHIPSO works on the CTAP program, which ends September 30th. So there's about 2 more weeks for the 5-year program that CalHIPSO and 3 other contractors through the state have been assisting. And though the CTAP ends, everybody should be aware that there is stage 3 meaningful use reporting up through December 31st. So you have that time to be able to meet meaningful use. There are some organizations who are testing now, and they're able to earn some incentive dollars from being a meaningful user to help fill some of the gaps that have been suffered through lower office visits and whatnot due to COVID. So if you haven't been focusing on meaningful use yet this year, please contact myself. Even if you're not a CalHIPSO organization under CTAP, I can reach out to my counterparts and certainly share the assistance that is out there. So we'll reach out to Paul and OCHIN for ECR, come to CalHIPSO if you're looking for any stage 3 meaningful use. I don't have any other new questions, so Paul, thank you very much, and hopefully everybody can benefit from 18 extra minutes on their day, and this will be recorded and posted, and CalHIPSO sends out a link to the recording to everybody who had registered.
Great.
Thanks a lot. Stay safe, everyone.
Thank you, everybody.